All right. So good afternoon, folks. Welcome to our webinar hosted by the American Public Human Services Association, or APHSA, in collaboration with Deloitte. Today's webinar topic is supporting PHE coverage and navigating transitions for Medicaid populations. Next slide. So my name is Adrian Saldana, and I am an organizational effectiveness consultant at APHSA. I'd like a minute to share with everyone an overview of APHSA and the work we do for and with our members. APHSA represents state and local health and human services agencies from across the country. Next slide. We aim to deliver to our members through three core channels: influencing modern policies and practices with the goal of strengthening communities, building capacity through our conferences, technical expertise, publications, and OE consulting, and connecting members across a wide circle of stakeholders and partners in the health and human services sector. Next slide. So speaking of connecting members, I invite you all to save the date to one or all of the APHSA conferences we are hosting in 2023. Our National Health and Human Services Annual Summit will be in Baltimore, Maryland, May 21st to 24th. And our Economic Mobility and Wellbeing Conference will be in Long Beach, California, August 27th to 30th. This year, our Information Technology Solutions Management, or ISM conference, will be combined with our annual Attorneys Education Conference from September 10th to 13th in Kissimmee, Florida. And our Staff Development and Training NSDTA Conference will be in Pittsburgh, Pennsylvania from October 22nd to 25th. Check back on the APHSA website for more information, including when registration opens for each conference. So during this webinar, we are requesting that you put your questions for our presenters in the Q&A panel rather than the typical Zoom chat feature. If possible, panelists will try to answer questions during their presentations, but there will also be time left at the end for questions. And now it's my pleasure to introduce our moderator for the panel discussion, Rebecca Hildebrand, a principal at Deloitte Consulting.
Thanks, Adrian. Hello, my name is Rebecca Hildebrand, a partner at Deloitte, as Adrian mentioned. I'm out of our Boston office. I live there with my husband and my 3-year-old daughter. And as you might be able to relate, we're dancing to a lot of Frozen and Encanto songs at our house these days. I lead our LTSS, or Long-Term Services and Supports practice nationally for Deloitte. And I spent a lot of time supporting our HHS clients with their technology transformations. I am really excited about the presentation today. We will be talking about the PHE Unwind, but with a focus on the LTSS population. So this includes individuals in nursing homes, as well as individuals utilizing home and community-based services. I am so grateful for our state speakers from Kentucky who have joined us today. And I appreciate that they have taken the time to share their approach with all of you. So first, we're going to start with some intros. So first, let's go to the Kentucky team. Pam, will you please go first?
Yes, thank you, Rebecca. My name is Pam Smith, and I have been with Kentucky, have lived in Kentucky all my life. I currently am the director of the Division of Long-Term Services and Supports with the Kentucky Department for Medicaid Services. We oversee 6 1915C home and community-based waivers, as well as home health, private duty nursing, our nursing facility, our PACE program that just launched. I'm really excited about what we see for the future for Kentucky and about being a part of this. So, Leanne, I'll go ahead and turn it to you next.
Hello, my name's Leanne Mullins. I've also lived in Kentucky my whole life, been with the state about 22 years. I'm the director of the Division of Eligibility Systems, and we provide support for the Integrated Eligibility and Enrollment System, which of course supports Medicaid. And I'll turn it over to Seth.
Thanks, Leanne. Hi, everybody. Just to complete the theme, I'm also a lifelong Kentuckian, and I have background about 8 years on the commercial healthcare technology side and a few roles in operations, software management, some program and project management. In the last 6 years, I've moved over to help support the Commonwealth and a program management role as well.
Perfect. All right. Thank you, Team Kentucky. Let's go to the Deloitte team. Scott, please.
Good afternoon. My name is Scott Workman, and I've been working with Health and Human Services states for longer than I care to admit, more than 25 years now. And a lot of that more recently working with LTSS and waiver populations and at-risk members of the Medicaid community, as well as the providers and the other stakeholders, all of whom are going to have to come together in a very orchestrated and thoughtful way to minimize any adverse outcomes from the PHE Unwind. And, you know, I'm not a huge football fan, but I watched a number of playoff games this weekend, and it kind of reminded me that even when you've got a really good plan, you know, halftime adjustments are pretty important to the outcome. And we'll talk about a few strategies with that. And we look forward to this being part of an ongoing dialogue. So looking forward to a fun afternoon.
Good analogy. Thanks, Scott. Jessica, please.
Yep. Hi, everyone. Jessica Liefelt. I'm a leader in Deloitte's LTSS practice. And though I am not a lifetime Kentuckian, I have been working with the state of Kentucky or the Commonwealth of Kentucky for 10 years. Both with Leanne and Pam, including working on the HCBS case management solution since its inception back in 2013. So happy to be here with y'all.
Perfect. Thanks, Jessica. Next, I'm going to go through the agenda. So first, I'm going to spend just a few minutes on PHE Unwind overview, just to set context on some of the basic points. Then we'll proceed to the spotlight on Kentucky. Then Scott will bring us through some leading practices we have gathered across many states we have the great opportunity to serve. And then lastly, we'll move to Q&A. And Jessica will be helping me manage that at the end, where we've left some time, about 10 minutes. But throughout the presentation as well, please feel free to ask questions as we go. So why are we here today? There is a lot of good material available on the PHE Unwind, but there doesn't actually seem to be that much out there that focuses on the LTSS population specifically. And although this population is the least likely to lose coverage based on eligibility, this is certainly the population that is at most risk if they do lose coverage. And this could be for whatever reason. So maybe the person moved within the state or to another state. Maybe the staff at the nursing home who usually handle the paperwork is 100% new. But regardless of the reason, there are potentially large impacts to individuals who are receiving LTSS who lose coverage. So let's move to the brief overview of the Unwind. So I am sure that many of you recognize this timeline that came from the CMS communication earlier this month. We're not going into the details of the CMS guidance, but I'll just summarize the key points for context for our conversation. So starting the week of 17th, of January 17th, which is this week, CMS will have individual meetings with each of the states to discuss final unwinding plans as well as system readiness plans. Then in February, there is a lot of documentation, as many of you know, that needs to be sent to CMS. So if your state is planning on initiating the renewals process in February, the documentation is due on February 1st, as you can see. This includes the renewal distribution plan, the system configuration plan, and the system test plan and results. However, if your state is initiating renewals in March or April, the documentation is due just 2 weeks later on February 15th. Finally, the continuous enrollment condition expires on the 31st, and then terminations may begin the next day on April 1st. And then also worth noting, you'll see this at the bottom, the baseline unwinding data submission dates will vary by state, depending on what month you're initiating the renewal process. This is either February 8th, March 8th, or April 8th. So it looks like the dates are coming up fast, and they are. But today, what we're going to talk about are things that can be done in the short term to augment your current preparation plans, like whatever you're doing now to prepare for those dates that I just mentioned, but also things that can be done to potentially improve your approach during the unwind period itself. You know, like what Scott mentioned about halftime, like what are the things that can be done even after you've started the unwind process to potentially incorporate lessons learned or things that have occurred during the beginning part of the unwind. Okay, so we want this to be a forum where ideas can be shared between all of you as well. There are a lot of you on this call, so please use the Q&A function throughout the presentations for questions, of course, and we would love to hear your questions. But feel free to throw in ideas that are working well for you and you want to share them with everyone. This is not going to be easy, but we are all in this together. So why don't we bring up a couple of poll questions before we move on to the Kentucky Spotlight. So the first question is, do you have targeted outreach campaigns for any of the following? And if you could check all that apply, that would be great.
And while folks are doing that, Rebecca, us hosts don't get to vote, which is too bad, because I was going to be happy to vote on behalf of New Hampshire.
What would you vote for on behalf of?
Most of them.
Most of them.
I would have voted most of them.
All right. Well, why don't we close this one out? Do we want to give it do we have a lot of responses? Natalie, ready to close it out, do we think?
I'll give it just a few more seconds. They're rolling in.
Okay, perfect. So I'll just go through then. Managed care organizations, nursing home direct service providers, targeted case managers, advocacy organizations, hospitals, community mental health centers, aging and disability resource centers, and direct to Medicaid recipients and or families. Okay, let's see what we got. Okay, so it seems like the most, about half of the respondents are doing targeted outreach to the Medicaid recipients and or families guardians, which makes sense for the target audience that we have here today. Is there anything, for the panelists or people can put in the chat, anything surprising that people see?
Well, I don't know if it's surprising, but what it kind of shows is that there are some edge opportunities to do more from a communication perspective to get all those stakeholders involved and get them to be part of the solution versus the ones throwing stones when it doesn't work. So the rest of the conversation should be super relevant.
Okay, fantastic. All right, Natalie, will you please bring up the next poll question, please? Okay. Are you using these modes for targeted outreach? And mark any that apply. So mail, snail mail, email, text, text campaigns, phone, robocalling, social media such as Facebook or Twitter, town halls, or anything else. And if you hit other, I would love for you to put some additional information in the Q&A chat, please. Scott, for New Hampshire, what would you answer?
I would answer all of the above except for robocalls. Direct to consumer calls, yes, but robocalling, no. Everything else would be an absolutely for sure.
All right, Natalie, I think we can close this one out. And what do we see? Okay, so it looks like what most people are using are mail and social media at sort of the top. Again, Scott, anything for you, comments or things that surprise you off of this list?
No, I think it's just the same as the prior slide. There's lots of opportunities to get closer to folks. And the other thing we could have asked here is which of these modalities are being used not just to get to the members, but to get to the providers, the advocates, the targeted case managers as well. And we'll talk about that more as we roll through the conversation.
Okay, perfect. All right. So now we're going to hear from our partners from the Commonwealth of Kentucky. I live in a Commonwealth too, so really important to get that right. About their PHE unwinding efforts overall, including the focus on the LTSS population. Where I feel the Kentucky team has really excelled is in the creation of their self-service portal and enables participant and their support network. So family, authorized reps, and support coordinators to access information about their benefit programs and plans. This portal will be extremely helpful in supporting their unwind efforts, and I know they're going to highlight it as part of the discussion. You'll also hear how Kentucky is using the concept of nudging to minimize the impacts on participants during the unwind. I think at this point, nudging is a pretty common term, but for those of you who don't know what it is, you'll get to hear a little bit about that. In addition, the Kentucky team will talk about how they've implemented oversight and outreach in this process to those enrolled in the waiver programs, and they'll talk a little bit about that. So now I'm going to hand it over to Leanne, and Leanne is going to start us off by discussing human-centered design and the authorized representative capabilities within their technology solution called Connect.
Hi, thanks, Rebecca. So a little bit about Kentucky's SSP redesign. We actually started this a couple years ago, so it was kind of like we knew public health unwinding was going to happen. But we did notice a few years ago that our SSP utilization was low. We only had about 39,000 unique visitors a month. But after we went through all of our redesign, we had an increase of like 246%. So it was really amazing. We worked with Deloitte to reimagine what that user experience might be for our stakeholders. We had a lot of feedback from actual users. We had collaboration with our agency partners, users. We went out into the field and talked to people. What kinds of things about the self-service portal are intimidating? What would make it easier to use? We found that in our initial development, we used a lot of the language within our worker portal that's specific to, our workers who are trained. So a lot of that language didn't translate to users. So a lot of time was spent on finding, what the right language would be, the right wording to help convey what information our workers need to determine eligibility, but also be able to capture that information from end users. And while we did that, we used personas, looking at different user journeys, what barriers, motivations. Kentucky is very rural. We have, that was a huge population that we worked with. So over the human-centered design time, we interviewed 152 customers and workers. There were a lot of JAD sessions and a lot of just sharing of ideas. So we had about 9,000 cases managed by 200 organization authorized representatives across 38 organizations in the community. And another 600,000 plus cases that are associated with authorized reps. So that was also another, I don't want to necessarily call it a roadblock, but it was a bump in coming along to get eligibility determined. So those were all different aspects that we really wanted to hit on with the human-centered design experience. So our main items were we wanted to increase end-user adoption, make things more user-friendly. We also wanted to enable analytical capabilities so that we could obtain more information. Like we knew we had 39,000, but how can we increase that and have usable trends to report on that moving forward? CMS likes a lot of that information. You have to provide it in your APD, so it was definitely useful. We also reviewed all of our key processes and policies, how to train staff. A lot of staff wanted to continue to see people. But we really wanted to push people to go into the SSP so that our workers had more time to actually work the cases. And then through the HHS authorization, we were able to transform benefit case processing and introduce incentive-based partnerships. So we think it's been really successful. Next slide, please. Okay, and our key benefits or key features for the authorized representatives, as already mentioned, it allows our organizations or authorized representatives, we have agents and connectors that assist. It gives them their own dashboard, so they're able to go back and follow up with their users, help them figure out, okay, you have a request for information out. So it gives them a great tool to help people to obtain eligibility. We've also had streamlined electronic access requests. So while you're sitting with an agent or a person to do an interview, we still need to make sure that, you know, we have their permission for them to be your authorized representative. That's all automated, and it happens, I think, within 90 seconds now. And if then you're able to associate your case with that authorized representative, whether it be an agent or a connector, or you know, I could even do that as say for a family member. We also have dynamic program level permissions, mostly Medicaid, but we have recently also introduced the concept of having authorized representatives assist with SNAP and TANF and child care. So, but if I only want, you know, that person to be able to help me with my Medicaid, then I don't have to give them the ability to help with SNAP as well. We also, when we started this project, we did not have a mobile app. So that was very important as well. So we used the mobile first approach, you know, making sure that everything would configure to whatever app, whatever device people were using, whether it be a laptop, desktop, or mobile, iPad, whatever. And that was also a very huge part of our redesign to help promote use. We also heard from workers that there were sometimes some issues with the way maybe an end user entered income. They might not understand the different concepts or exactly what was being asked. Like, you started a job, but you ended a job. How are we supposed to report that? So we also used WalkMe whenever we were redesigning to help people walk through that process. We also did that with document upload, just to help users be able to work through that process a little bit smoother. So, okay, and that's it for me, and I will turn it over to Seth now. Thank you.
All right, thank you, Leanne. So guys, I'll be walking through our 4 email and SMS nudging campaigns. In this slide here, so we'll start with this one, where on the left we have some blue boxes that kind of show where we had identified either some gaps or needs or opportunities related to outreach communication needs. And then on the right in green are the solutions that we came up with that are actually the 4 campaigns that I'll walk through in a little more detail in the subsequent slides. But just to start, in the prepare box, you know, it's very hard for someone to understand what's going on if we can't get them the information they need and we don't have their correct address. So our very first step was, let's try to reach out to these folks and try to get them to, you know, receive an email, receive the SMS that we have for them, make sure they can see the address we have currently, and if it's not accurate, for them to go in and update that. And we actually had quite a bit of success with that. And I think the very last slide, I'll show you some metrics on how that went. And then secondly, you know, we wanted to make sure that these folks were aware of the coming changes. So for that campaign, it was more of a general awareness, 90 days out. Here's your renewal date. Just be aware that some communication is coming, just to get them, you know, aware and be prepared. And the next step under the guide box, closer around 60 days, it's, you know, time to help them be aware of those renewal steps they need to follow. This communication, you know, once again, gave them the date and some of the next steps, and trying to encourage them to get into the system and do what they need to do to get their renewal going. And then lastly, in redirect, so for those folks that do come off of their benefits after the unwinding, we want to be able to show them some alternative options so they could be eligible for other coverage. We want to make sure that they're aware and try to encourage them to go in and apply for those if they can. So those are the 4. So the next slides, we'll go through those in a little bit more detail. The first one was the address update that I mentioned. So a couple of things here. You know, our target audience we identified were, you know, Medicaid recipients that could require renewal when the PHE unwinds. So identifying those folks, getting them either the email or SMS based on the information that we had. The goal here is to get these addresses updated so our delivery accuracy improves. We reduce the risk of people falling off by not getting communications that maybe they would need to engage in renewal. And then also we want to give them an opportunity if they weren't opted into our digital communication, email or SMS, that they can do so through this nudge. So on the right, you can see an example of what this email would look like. Try to keep things simple, pretty straightforward, showing them their current address, just asking them to think, is this the right address for you currently? If not, please go down and access the dashboard, update that address so we can reach out to you all with the notices that you need to receive, and then also asking them to update their notification preferences in case they prefer to continue to receive emails or SMS. The second campaign to follow up on this next slide is, so this is 90 days out, same target audience, but the goal here is somewhat overlapping, but also a bit different. So again, we're trying to encourage folks to keep their information up to date. So we have a little bit of verbiage in there about that, but primarily wanting to show their renewal date, make them aware that they will be getting some information that they'll need to follow up on. And then once again, also putting a little prompt in there for them to update their notification preferences, just so we can keep our communication as accurate as possible. And then on the follow-up from there, now we're going to be 60 days out. And this one is a little more actionable. So again, same folks, but now, we're to that point where we want to get them logging in and start taking some action. So we have some of the same information. This is your renewal day, but we need you to, log in here and start working on some of these recertification tasks. So goal here is somewhat similar. Definitely want to get folks in there to do the work that they need to do so we can get them renewed, and hopefully this would reduce the number of discontinued cases that don't need to happen, reduce churn, and then if we can achieve those things, that's also going to be a benefit for the call center staff and our BPBS folks who are assisting these people. So a few goals really for each of these, but all kind of rolling up to these bigger goals of this, let's not increase churn. Let's try to keep it as low as possible, and hopefully that these notifications help people be more aware and give them some time to take the appropriate action. And then lastly, for folks that do have coverage discontinued for whatever reason, we want to assist them in or at least in helping them be aware of other options out there for them. So this is a little bit more targeted. So it's going to, hopefully be a much smaller group. We want to, explain, as you can see on the right, like why you lost coverage, and then some other steps that they can take to see what other assistance maybe they would be eligible for, so they can reduce any potential lapse and get the benefits or coverage or that they're entitled to based on their eligibility. So those are the four-pronged approach. And then on the last slide, I'll give you some metrics on the address update. So this was actually quite successful. We almost sent 250,000 emails, 6,000 SMS with quite high delivery rates, which is good. They're not bouncing back. 42% of the folks opened emails, which was really quite high, and it resulted in 132,435 address updates, which is tremendously helpful for reducing improving the delivery rate and making sure that we are getting the key information to folks on time and to the right place. So we're really pleased with this. I was honestly somewhat surprised with the number of updates, but we're really happy that was successful. And that's what I have for you all. So I'll hand it over to Pam. Thank you.
Thanks, Seth. So I want to talk specifically about our home and community-based waiver program. So we began actually back in 1987 when we introduced our first home and community-based program. And over the years, that has grown to a total of 6 programs serving over 24,000 residents. I actually was looking at updated numbers earlier today, and we're actually coming close to the 30,000 participant number, which is great because that's less individuals that are in facilities. But, you know, that in and of itself brings challenges. So just to look a little bit more at our populations, we have 2 waivers that focus on individuals that have a brain injury. We have 1 waiver, which is our largest waiver, the HCB waiver, which is confusing, right? Because they're all called home and community-based waivers, but we have one called HCB, and coincidentally, it was our first waiver. But it serves mostly our aged population, individuals with physical disabilities, or those individuals that have medical issues that are medically fragile. We have 2 waivers that focus on intellectual and developmental disabilities, which is our Michelle P. and our Supports for Community Living waiver. And then our smallest waiver serves individuals that are ventilator dependent for 12 or more hours a day. So this population in general is harder to communicate with sometimes. So it brings challenges on how do you get messages out to them that are as important as one like this for unwinding. How do you make sure that they understand what they need to do? When some of them, it may be them alone, it may be they do have natural supports, they may be in guardianship, and then, or their case manager or their waiver provider may actually be their natural supports, and how they get their information, and they look to them for a lot of guidance. So we had to really think about ways to combat that and how to make sure to get that information to these individuals so that they did not, you know, accidentally lose their coverage just because they missed providing information for a renewal, or they missed a step that had they been in a nursing facility, or if they did not have a disability, that they may have been able to meet easier or have someone to assist them. The other thing that we've learned that's been very interesting with this population is written communication always does not work. A lot of times we used to laugh, and it changes as the logo changes. So, you know, we used to say, oh, if I get a letter and it's in the horse envelope, because, you know, it had the little, you know, that in the corner, I don't want to open that because that's bad news. Or, you know, so now it's, oh, if I see that state of Kentucky, I don't want to open that because that's bad news. So that led us to think about how can we use some of the supports that we have in place through our case managers, how we can use that to help these individuals to make sure they don't accidentally lose these services that are so critical for them to be able to remain in the community. So we can go to the next slide, please. So what did we do what did we do to minimize that impact? So because we have a shared application that Jessica had referred to, our case management solution, our Medicaid waiver management application, it allowed us to, we're able to look at those individuals that are enrolled in waiver programs and in conjunction with Connect, we know who may be at risk of losing that Medicaid eligibility. And we have that information of, you know, their contact information. If they have an authorized rep or a legal representative, we have that information, as well as we have their assigned case management. And that case management provider is really going to become, a lot of times it is a lifeline for them, and they're the ones that help to do these types of things. They're a representative themselves that are able to, you know, contact the DCBS office, or to go to the worker's office, or to go online through the Connect application and complete this for them. But we had to think how is best not to overwhelm the case management agencies, as well as reach the individuals. So after we identified who is at risk for losing that information, then those case management agencies will be contacted, and they will know who's at risk for losing it, and what is going to happen if they do. So the case manager will then be able to talk to their client. And again, like I said, that's that face-to-face contact or a phone call from somebody they're very familiar with. So it's not as scary as I'm getting a letter in that envelope, and that must mean that something bad is happening or I'm going to lose something. So that really helps to make sure that either things get done prior to disenrollment, or if for some reason they are in that period where they are disenrolled, that we are able to get that resolved quickly so that we can minimize any negative impacts for those individuals. Because at times just a week, losing a week's worth of services, it may mean the difference of whether that individual remains in the community where they would like to be, and whether they're at risk for either going to the hospital or going back into the nursing facility. So we want to minimize any of those negative impacts or any of the adverse impacts it could cause on the individual's care. And so I will turn it back over to Rebecca now.
Great. Thank you so much, Pam. That was awesome. That was a great presentation and so many good questions. So thanks, everyone. Scott is answering some of the questions and our team is in the chat. Jessica, do we have any questions that we'd like to try to answer now live that maybe we haven't answered in the chat already?
Well, I do see that there was a follow-up question on the database of information that states are doing, the best way to reach out for that aggregate info. Scott, I'll let you answer this if you can.
Yeah, I'll share two things. So the first thing I'll share is for the states that we're working with, we are seeking to compile an inventory of which states are using what strategy. And, we generally don't like to share things on a state's behalf, but we can share an aggregate. This many states are going chronological. This many states are going based on vulnerability, or talk about those patterns. So if somebody can reach out to me or to one of the other panelists, we can happily work through that. CMS, of course, will have this data for all states. And should they choose to share, we'll have a complete inventory on it. And I wanted to answer another question in the chat too, which is, some states are not going by a vulnerability or a similar schema. They're going by kind of first in, first out, like what the sequence would have been in the natural order of things. And there's concern that that will cause chaos because people will hear, oh, this unwind is happening, but they won't have their request for renewal because they're further out in the cycle. And they'll start calling, and providers will have anxiety and clients will have anxiety. So one of the things we're seeing states do there is finding ways to prospectively share those renewal dates, even if they're 12 months out. That can be a letter or text and email using the capabilities that Team Kentucky went through right to the consumer. It can be providing a nursing home a roster of everybody enrolled in that nursing home and when their renewal is scheduled. It can be doing a feed to the MCO with everybody's renewal dates. So when the MCO gets called, they can tell an individual or a provider when that MCO is due, or when that client is due for renewal. In the self-service system, it's putting the renewal date right at the top of the homepage when you log in. And it's probably in your wait talk track for your call center, explaining to folks how they can get this information without having to talk to a live agent. So those were a few examples. I do encourage states to find a way to communicate that prospectively.
Perfect. Thanks, Scott. Jessica, any other questions that we want to try to answer now?
Yeah, it looks like we've gone through and answered most of them. Oh, we got a couple new ones. Do recipients have to get their income reviewed again for continued eligibility? Leanne, do you want to answer this from Kentucky's perspective, or Scott generally?
So, I mean, the short answer is yes, but you can use ex parte and passive renewal. And if you can verify that the income is consistent with what you have, or under the categorical threshold, or some other similar sort of disregard compare logic, then you can go passive and ex parte. And if you don't have passive and ex parte in place already, there are some, I'll call them shortcuts that can be used to get a similar benefit. And it would probably take longer than we have on this call to explain how to do that. But there are options that we can run through through there with folks if that's an area of curiosity. And I'll make one more point on that. Most of the states that I've talked to, and that's a pretty long list, have looked at ways to expand the number of passive or ex parte renewals to drive down work for clients and caseworkers, and have changed or in the process of changing their verification plans to have a broader, more all-encompassing ex parte passive renewal strategy. And if you work with a state that hasn't done that yet, we'd be happy to have that conversation. It's an important one. And as it relates to this group, it is applicable to non-MAGI Medicaid members, where we generally see lower passive ex parte rates, and states that have been creative have managed to push those numbers up in addition to the MAGI passive rates. So there's definite juice to be squeezed there.
Great, thank you, Scott. Jessica, anything else before we move on to the next section?
Leanne, do you want to add anything else on the redeterminations? I know Scott already mentioned the chronological order, but do you want to talk any more specifics on the
We are looking at also realigning any Medicaid recipients that also receive other programs. So if their Medicaid renewal might be due, on into the year like October, but they have a SNAP renewal that's due in March, we're looking to try to realign all of those and match them up. So the person only has to, touch base one time. Chronological is obviously, I think the most logical method at this point, but we are looking at other ways to enhance that throughout the process.
Awesome. Thank you so much, Leanne. All right, why don't we go to the next section? And to start this one off, so we're going to do leading practices, and Scott's going to lead the discussion on that. But first, we're going to go to another polling question. So do you have preemptive outcome strategies analytics to encourage waiver program renewals and or avoid program closures? So yes, no, or unsure. All right, Allie, why don't we close this one out? Unsure. Okay, well, then this is the right place to be. And Scott, this might inform a little bit about what you're going to present on next. So why don't we move on to the next topic?
Yeah, and before we do, there's two questions in the chat. I figure it's just easier to address them right now.
Yeah.
The first one is, will all the Medicaid beneficiaries receive notices, or just those in the PHE? So there are two things that happen, starting in April or earlier, or maybe a little bit later, depending on your state strategy. One is normal renewals begin again. So people that are not presently protected, will be required to complete their normal renewal per your state plan and policy. And then the protected folks have to be distributed within the 12-month window provided by the omnibus. And that's where you have that discretion as to how you manage that distribution. In general, most folks will get a renewal. There are some exceptions where you might have a change report for somebody that had a renewal in the last 12 months, where depending on your interpretation of guidance, you could possibly close them or extend them without doing a renewal. But those are edge use cases that are really situational to a state's interpretation of guidance. And the FMAP question, I'm not sure I understand the question. CMS did provide the FMAP drawdown strategy that ends at the end of the year, which is longer than the window allowed to unwind. So the enhanced FMAP will go away before some states complete unwind. The unwind strategy can't be driven by FMAP incentivization, as I understand it, but it is certainly a calculus as states look at how quickly they're going to unwind relative to what their budget can sustain. I don't know if I got close to that question or not.
And if not, just please type a follow-up question. We'd be happy to take it. All right, Scott, let's move into your section.
Yeah, so I'm going to spend very little time on these goals. Matter of fact, I think I'd rather just buzz ahead of slide, and I'm going to go a little bit off script because the speakers that came before me hit on a lot of these things, but there are a few things that I think might be worth calling out. The first of which is we talk about this as the LTSS community, right, and the waiver community. I often think of what we're trying to do here as the vulnerable community in Medicaid. And so I would encourage states to think a little bit more broadly about what they do for the waiver population and who's in a similar risk profile. So for example, people that are in the middle of SUD treatment, losing their Medicaid can be a pretty traumatic and detrimental experience. Or folks who have high cost claims utilization and might be waiver candidates, but because of the PHE just continue to get services through the traditional MAGI Medicaid programs, and they might lose that eligibility. And, you know, with things being out of their natural order, didn't know or didn't think to apply to the waiver programs. And so what I'm suggesting here is that whatever strategies the state is putting in place for LTSS get extended more broadly to what I'll call the high risk population. So then the question becomes, okay, if you've got a high risk population, whether it's LTSS or SUD or high volume claims utilizers, how can you help them maintain healthcare continuity in a way that's sustainable for you? And what I would suggest is that it starts with an ecosystem perspective. And here's what I mean by that. The MCOs are incentivized to get to a good outcome because everybody that closes is going to be somebody for which they don't get a capitation payment. And or several of the MCOs often participate in the exchanges. And if there isn't healthcare continuity, you know, the exchange healthcare providers will also have a lesser market opportunity. So providing the MCOs rosters of who is going to be going through the renewal, when, and what their circumstances are, position them to help you. So if somebody is protected because they didn't do a renewal, the MCO should be coaching and incentivizing people to do the renewal. If they did the renewal but over income, the communication becomes a little bit different, and maybe we're talking about healthcare continuity coaching. But the MCOs are a very powerful and persuasive arm for client outreach. And a number of states are literally incentivizing or penalizing the MCOs through their contract, and in particular, as it relates to the waiver populations where the MCO is supporting a waiver population. So if they know who's getting a renewal and is protected, they can help. They can also potentially help, and I think CMS has supported this in some guidance, with people who close administratively and helping them come back again. So the next one is the providers. Many states don't traditionally have a direct-to-provider renewal roster capability, but some do. So in some states, a nursing home provider can log into a portal and see every participant in that nursing home who has a renewal coming up in the month ahead. And they can see the members in a given renewal month who haven't renewed or who have pending verifications, and they can help assist them to getting that renewal complete. And if you inform that nursing home, targeted case manager, primary care provider with enough information on who is protected and getting renewed and what their circumstances are, then they become allies in getting to the right place for that citizen or that consumer of Medicaid, and they're part of the solution. Conversely, if a nursing home doesn't know that 50 people at their facility are up for renewal in a given month, and a bunch of them close because there was confusion, that nursing home is going to call a legislator, hit the call center, call your Medicaid claims billing unit when their claims stop paying. Like, it's going to create chaos. So whether it's through a provider portal, whether it's through a secure file exchange, there are a lot of different ways to get there, some of them more stopgap than others. We really encourage folks to communicate with the providers and the MCOs directly, and any other advocacy groups that you feel can help move the needle, like the SUD providers. Do you know the answer if it's legal to tell the MCOs that someone is over income? I know that certain states are telling MCOs when they're terminated what the termination reason is. So although I'm not a lawyer and won't claim to be, I know that, you know, at least a few states are doing that, probably more. The other thing I wanted to talk about a little bit was building on the Kentucky use case and the nudges. And we can roll ahead a slide, although I'm so far off script, I'm not sure it matters. Lost contact, I want to talk about this one a little bit. Kentucky talked about it as well. But when your renewal for your LTSS member gets sent out and it gets returned to the mailroom, right? That's an easy case to reach out to the provider. And if you've got a text or an email for that client or for their authorized representative, to reach out through that alternative channel, in addition to any direct member calling or robocalling that you might be doing. And the omnibus guidance says you can't close folks without attempting multimodalities of contact where you get return mail. So I would encourage states to look at that and make sure you've got a text strategy, an email strategy, that you've got a way to reach out to the providers. Like if somebody's in a nursing home and they get disenrolled because you've lost contact with them, that's going to be an embarrassing news article. Like that person might have been in that nursing home for 10 years, they're still there, and the renewal bounced back because their authorized rep changed addresses and we didn't know about it, right? Like there ought to be a way to get to that provider and have them help solve that problem for us. And if that auth rep has a text or an email in your system and you hit them through that channel, then you've secured and closed that down. By the way, I am not watching the chat right now, Rebecca, and I know we're drifting in on time. So if there are questions, if somebody can do a shout out on that, that would be fantastic.
Yeah, I think, Scott, we have about 8 minutes left. So maybe you could, so there's one question, this might be go well with what you just said. Is CMS going to provide the multiple modality guidance or will it be state discretion?
So they provided guidance, but they haven't said specifically how they would define the modalities and what is required to close. So they haven't said, okay, if you mailed and text, 2 weeks after you send your text, you can close. They haven't provided that. At least one of the states I'm working with, when they have their CMS check-in that you talked about in the timeline and like way up at the start of the presentation, we're just going to tell CMS, this is the lost contact strategy, and put it in writing. And, hopefully they'll either affirm it and approve it or provide some guidance at that point. But at this time, I haven't seen them provide anything definitive that says exactly how that process could or should work. They've just kind of set a somewhat arbitrary bar.
Gotcha. I think, Scott, so we have about 7 minutes left. So I just want to put in a plug for you. You should definitely continue. But if there are questions, this is a good opportunity to ask them before we close out, because I'm sure we want to try to close out on time.
Yeah, and I do want to hit one thing first. Like I've been talking a lot about how to avoid the problem, but the second part is, what do you do when it occurs, right? Like large numbers of LTSS members should not be closing with Unwind, right? So it's important for states to have checks and balances, particularly if they have auto closure jobs, and even for worker closures, that a disproportionate number of people aren't closing due to administrative complications. Because if there are, that's probably time for one of those halftime adjustments and some direct-to-provider, direct-to-client outreach, whatever needs to be done there. But if you don't set the checks and balances, you won't know, they'll just close and you'll be dealing with it after the fact. And to that same effect, having dashboards, we're finding a lot of states really want to have dashboards of per renewal month and showing incrementally throughout the month how many people are getting where they need to be, how many people are at risk, what is the backlog in the mailroom, what is the backlog in document indexing, what is the caseworker backlog on verification processing. And that's so that people can stay informed. During the rush to apply for uninsurance, at the beginning of the PHE, way back when, the lack of knowledge as to how long the bottlenecks were in the community caused zillions of calls to come in. And so then people started communicating, hey, we're at a 15-day backlog. Don't call us. We'll let you know when we get past our backlog. I'm going to pause there, Rebecca.
Yeah, there's no other questions in the queue. So maybe one more key point and then we can close out if there's no other questions. If there's anything else you wanted to add with your section.
So the only thing I'll add additionally is a number of states are kind of retraining their teams because they haven't done renewals for a long time, right? And so they might not have done a renewal where they have to verify assets, for example, in quite a while. And, you know, some of these folks might roll over in a spend down and they might, you know, not quite remember how to manage those spend down bills. So we are seeing states sort of looking at what are we going to ask the workforce to do in addition to do we have enough bodies or a strategy to deal with the volume? You know, is the staff prepared and informed on what they need to do? And if confusion develops as to how they can administer their tasks most appropriately, how do we get FAQs and in the moment trainings out there in a way that's effective? So some of those little mini spot educations that Kentucky was talking about, you know, can apply not just to clients, but to caseworkers. And, you know, just positioning the casework teams to be as successful as possible will reduce their stress, their anxiety, and increase their accuracy. So there's some opportunity there as well.
Okay. One question for you. Any leading practices for states where state employees don't process renewals? Counties do all the work. No way to create 87 backlog dashboards.
Well, so I was going to say you got to start with monitoring it to know, right? And to be able to communicate. It sounds like that might not be an option. You know, that's one where you got to look at where are the bottlenecks and what levers can you pull to reduce those bottlenecks, and how can you see which of those counties are doing better or worse and why. You know, it's way too complicated of a problem to have, you know, an easy, ready answer to, but there are definitely things that can lessen that pain and challenge.
Yeah. And going back to the question that you were answering before, you're talking about workforce, not only retraining, but training in the first place. I mean, I think we're seeing, and I don't know if this has come up with the states that you're talking to, but there's been such a turnover. And in fact, a lot of states probably reduced the workforce that they had and now are building back up with completely new people. Is that something you're seeing too, Scott?
Yeah, it is. And, you know, there are discrete strategies that states are developing for things like hiring campaigns, right? Like, how do we get better at hiring? Where do we want to do staff aug? By the way, somebody has a chat here that I want to get to, which is how do you convince the Republican legislators? So, like, I don't have the political pull to talk about one party versus the other, but what I will say is there are strategies through which you can reduce the number of people on the Medicaid rolls in a way that affects those who are much less vulnerable than others. So if you look at claims data, there are large numbers of people that aren't using Medicaid. So for example, there are substantial numbers of people whom you've lost contact with and aren't using Medicaid. Chances are they are not high risk members to close out. And so what I would say is if you've got to find the compromise there, maybe don't go first in, first out. Think about a vulnerability-based strategy that gives all of the parties something that they can feel good about.
Great. Well, thank you, Scott. All right, that's it for us. 1 minute left. I really appreciate, again, thank you to our Kentucky team. Really great presentation. Thank you so much for presenting with us. And thank you for all the great questions. The presentation will be available and we'll make sure that you have some contact information for all of us as well. If there's some follow-up questions we didn't get to, or if you want to take us up on some of the offers that Scott mentioned earlier. So that is all. Thank you all and have a great afternoon.